Hello everybody and welcome to our module on the endocrine pancreas. Recall that the pancreas is really two organs in one. There is an exocrine part of the pancreas that makes secretions which aid in digestion in the intestines, and I talk about the exocrine pancreas in the GI modules. The endocrine portion of the pancreas has cells that secrete hormones like insulin and glucagon. That's what we're going to talk about now. So you should know that the endocrine portion of the pancreas is made up of structures called pancreatic islets. They're also sometimes called the islets of Langerhans. An islet is a small island, and if you look at this picture on the screen, this is an islet here. It's an island of tissue found inside the pancreas, and there are millions of these in the pancreatic tissue, and these are the endocrine portion of the pancreas. There are a number of different cell types found in the islets, but one of the most important cell types are the beta cells. These are the cells that make insulin. They're the most abundant cell type in the endocrine pancreas, and they tend to be centrally located in the islets. You tend to find the beta cells more towards the middle of the islets. Other cell types you can find in the islets include alpha cells, which make glucagon, and delta cells, which make somatostatin. And the alpha and delta cells tend to be in the outer islet. They tend to form a ring around the beta cells, which are in the middle. We'll begin our discussion of the endocrine pancreas hormones by talking about insulin. Insulin is a protein hormone, and the word protein is very important. Insulin is made up of amino acids. It has a very different molecular structure than the steroid hormones like aldosterone and cortisol, which are made up of steroid rings, mostly of carbons and hydrogens. Insulin is synthesized by the beta cells, as I said on the last slide, and it's synthesized as a molecular structure different from the insulin that you find in the serum. Insulin is initially synthesized as pre-proinsulin. This molecule is made on the ribosomes of the rough endoplasmic reticulum. Pre-proinsulin is then cleaved inside the cell to a structure called proinsulin, which is transported to the Golgi apparatus. There it is packaged into secretory granules, and inside those granules, proinsulin is cleaved to become two structures. One is the molecule of insulin like you would find in the serum. The other is another structure called a C-peptide, which is a remnant of proinsulin that is left inside the secretory granules. To make this more clear, these are some pictures of the structure of insulin and proinsulin. At the top right of the screen is the structure of proinsulin. It has an alpha chain shown in green. It also has a beta chain shown in orange. Connecting the two is a C-peptide, which will be cleaved out before the insulin is secreted into the serum. At the bottom of the screen is the structure of insulin. You can see that it has just the alpha chain and beta chain connected by disulfide bridges. And I've summarized this on the left side of the screen. Insulin is made up of an alpha chain and a beta chain connected by disulfide bridges as shown over here. Cleaved out from proinsulin is the C-peptide. C stands for connecting peptide. This has a longer half-life than insulin, and sometimes we measure this and use it as an indicator of insulin production. Once insulin is packaged in the secretory granules, let's talk about how it's released into the plasma. Beta cells of the pancreas have transporters for glucose called GLUT2 transporters in their membrane, and these transporters will take up glucose and bring it into the cell whenever it's available. Once glucose is inside the cell, it will be metabolized by glycolysis and aerobic respiration, and it will produce ATP. The more glucose that's available, the more ATP that will be produced. ATP can close potassium channels in the membrane of the beta cells, and when it does this, it will cause potassium to be trapped inside the cell, and this will raise the resting membrane potential of the cell. This can lead to depolarization, and when that occurs, voltage-gated calcium channels will open and allow calcium to rush into the beta cell, and that will trigger the exocytosis of stored insulin. So via this mechanism, the more glucose that comes into the cell, the more likely the cell is to release insulin, and that's how insulin gets released in response to a meal and high glucose levels. A couple of comments on this overall process. The first enzyme for glycolysis in the beta cell is glucokinase. Recall that this is the same enzyme used by the liver, and we'll talk about why this enzyme is important in a minute. I point out up here at the top right of the screen here that the GLUT2 transporter and glucokinase are both found in the liver and the beta cell of the pancreas, and we'll talk about why those are the optimal transporter and enzyme for the beta cell in a minute. Another point here, there are anti-diabetic drugs called sulfonylureas, and they also close this potassium channel right here. Therefore, they trap potassium inside the cell and lead to depolarization and more insulin release. So as we saw from the mechanism on the last slide, when there is glucose in the plasma, this can trigger the release of insulin. You should also know, however, that many amino acids can also trigger the release of insulin. In fact, when you consume glucose and amino acids together in a meal, as you often do with most meals, the two of them together are a powerful stimulator of insulin release. Insulin release is also influenced by the sympathetic nervous system. The production of insulin from the pancreas is inhibited by epinephrine. The way epinephrine acts is somewhat interesting. There are beta-2 receptors in the pancreas, and when epinephrine acts on these receptors, it increases the amount of insulin that's released. However, there are also alpha-2 receptors found in the pancreas, and epinephrine can act on these receptors to decrease insulin release. And the alpha effect, it turns out, is what is the dominant effect in the pancreas. Therefore, as you know, when you experience the fight or flight response via the sympathetic nervous system, the result is to raise the plasma glucose level, and this should make sense to you. You want more glucose in the plasma in the setting of a fight or flight response. Let's talk in more detail about glucokinase. This is an enzyme found in beta cells that catalyzes the first step of glycolysis, the conversion of glucose into glucose 6-phosphate. This enzyme is also found in the liver, and I talk about it in more detail in the biochemistry module on glycolysis. This enzyme is activated by insulin, and in addition, insulin promotes its transcription. It also has several unique pharmacologic properties. It has a high Km and a high Vm. The high Km means this enzyme is more active when there are higher glucose levels, and the high Vm means it can convert lots of glucose, and both of these features make it a very effective enzyme for the beta cell, where you want this enzyme to be very active when glucose levels are high, and you want it to be inactive when glucose levels are low. Let's also talk in more detail about the GLUT2 glucose transporter. This is a bidirectional glucose transporter. It's found in the liver, kidney, and also in the beta cells. In the liver and kidney, it's important to have a bidirectional transporter because these two organs perform gluconeogenesis. So they need to be able to bring glucose into cells for glycolysis. They also need to be able to transport glucose out of cells when they are performing gluconeogenesis. In the beta cells, it also makes sense to have a bidirectional transporter so that glucose will move quickly in or out based on the plasma levels. When the plasma levels of glucose get low, this transporter will start to pump glucose out of the beta cell, and therefore insulin production will quickly fall. You can also find the GLUT2 transporter in some other places, like in the intestine and some other tissues. So I've summarized the key points about insulin release on this slide. Glucose is brought into beta cells via the GLUT2 transporter. Glucose is converted to glucose 6-phosphate via glucokinase. ATP is produced, which leads to closure of potassium channels, and that leads to depolarization. Voltage-gated calcium channels open, and the calcium triggers insulin release from vesicles. Everything we've talked about up to this point has involved the production and release of insulin from beta cells in the pancreas. Now we're going to talk about how the insulin hormone exerts its effects when it reaches target cells. And in order to understand that, we need to understand how the insulin receptor works. The insulin receptor is a tetramer. It's made up of 4 pieces. There are 2 alpha units and 2 beta units joined by disulfide bonds. If you look at this picture on the right side of the screen here, the green bars are the beta units, the blue bars are the alpha units. You can see that the alpha units are extracellular and the beta units are transmembrane portions of the receptor. Insulin can bind to this receptor. That's the first step in insulin exerting its reaction. And when it binds to this receptor, it activates so-called tyrosine kinase domains within the receptor complex. We'll talk about what that means in a minute. But what you should know is that the insulin receptor is often referred to as a tyrosine kinase receptor, and that's because it has these tyrosine kinase domains. At the top right side of the screen is the structure of the amino acid tyrosine, and there are many tyrosine molecules that are part of the insulin receptor, as I've shown in this drawing. When insulin binds to the receptor, those tyrosine molecules become phosphorylated by the receptor. The receptor phosphorylates itself, hence this is called autophosphorylation, by the tyrosine kinase domains that are part of the receptor. Once tyrosine phosphorylation has occurred, the next step in activation of the receptor is for the receptor to bind substrates. There are a number of these substrates. They are called IRSs, or insulin receptor substrates. There is an IRS1 and an IRS2. And these will bind to the receptor after tyrosine phosphorylation has occurred, and these IRSs will mediate the downstream effects of the insulin hormone. There are many elements of the way that the insulin hormone exerts its effects that are not well understood, but there are 2 biochemical pathways that have been fairly well characterized by which insulin exerts its effects. One of those is the PIK3 pathway. The other one is the RASP-NAP kinase pathway, and we'll talk about both of these now. These are pathways by which the activated insulin receptor can exert its effects on cells. The PIK3 pathway is the phosphatidylinositol 3 kinase pathway. This is a pathway that involves intracellular lipid kinases. If you look at the bottom right side of the screen, this is the chemical structure of phosphatidylinositol. You can see that it has long chains of carbon and hydrogens, therefore it is a lipid. It's also attached to a sugar moiety with a lot of OH groups, and these OH groups can become phosphorylated. If 2 of them are phosphorylated, the structure is called PIP2. If 3 of these hydroxyl groups are phosphorylated, the structure is called PIP3. And what the PIK3 pathway leads to is the phosphorylation of the 3' hydroxyl group of phospholipids so that more PIP3 gets produced from PIP2. Once the PIK3 pathway is activated, it catalyzes many intracellular processes. It's been shown to influence glycogen formation and fatty acid synthesis, and one of the most important things it's been shown to do is increase the amount of the GLUT4 glucose transporter that is present on the surface of cells. The GLUT4 transporter is stored in vesicles of target cells, especially in muscle, and the insulin hormone via the PIK3 pathway has been shown to activate the GLUT4 transporter. This is probably a major mechanism for increased glucose uptake. You know that the insulin hormone leads to more glucose uptake by cells and a lowering of the plasma glucose level, and this transporter via the PIK3 pathway is probably a major way in which this happens. This transporter is very important in muscle and fat, and it's been well described that insulin exposure leads to more GLUT4 on the surface so that glucose in the plasma can be brought into the cell. The second pathway that's been shown to be activated in response to activation of the insulin receptor is the RASP-NAP kinase pathway. Insulin receptors can activate RAS, which is a G protein found in some cells, and RAS can then activate many growth pathways. There are a number of these that go by funny names like RAF, MEK, and MAP. MEK stands for mitogen activated extracellular kinase. MAP is for mitogen activated protein. You probably don't need to know all of these, and we don't even understand exactly what they all do. But the net result of activation of the RAS-NAP kinase pathway is that this modifies cell growth and gene expression. And this is probably the major role of this pathway when it is activated by the insulin receptor. So on this slide, I've summarized some key points to remember about the insulin receptor. It is a tetramer of alpha and beta subunits with disulfide bridges. The alpha portion is extracellular. The beta portion is transmembrane. Insulin binding leads to tyrosine kinase activity of the receptor. It will autophosphorylate tyrosine residues. This can activate the PIK3 pathway, which leads to increased GLUT4 glucose transporters on target cells. The insulin receptor can also activate the RAS-MAP kinase pathway, and this can lead to growth and gene transcription. You should know that muscle and fat are referred to as insulin-dependent organs or insulin-dependent tissues. That's because cells of your muscle and fatty tissue use GLUT4 for glucose uptake. Therefore, they depend on insulin. If there's no insulin around, there will be no GLUT4 on the surface of these cells, and they won't be able to take up glucose. Many other organs and tissues are called insulin independent. Two of the very important ones are the brain and the red blood cells, which use the GLUT1 transporter for glucose uptake. This transporter is not dependent on insulin, and it will take up glucose whenever it's available in the plasma. This is important for red blood cells because they lack mitochondria and cannot perform oxidative phosphorylation, so they are entirely dependent on glycolysis to meet their energy needs. The brain cannot metabolize fatty acids, so therefore it is dependent on glucose and ketone bodies. Also, the liver, kidney, and intestines are insulin-independent organs. They use the GLUT2 transporter we talked about before, and many other organs are also insulin-independent, like the nerves and the lens of the eye. Now I'm going to talk about the effects of insulin on target tissues and cells. Much of this I discuss in greater detail in the biochemistry section. Insulin can promote glucose uptake, especially in skeletal muscle and adipose tissue, as we have been describing. Insulin also promotes glycogen synthesis. It activates the enzyme glycogen synthase, which makes glycogen. It inhibits the enzyme glycogen phosphorylase, which breaks down glycogen. Insulin also inhibits gluconeogenesis. It raises the level of fructose 2,6-bisphosphate inside of liver cells. This will then in turn inhibit the enzyme fructose 1,6-bisphosphatase 1, which is important for gluconeogenesis. Insulin increases fatty acid synthesis. It activates the enzyme acetyl-CoA carboxylase. It also inhibits the enzyme hormone-sensitive lipase. We'll talk more about that on the next slide. Insulin also promotes protein synthesis. It stimulates the entry of amino acids into cells. This leads to more protein synthesis, and this is important for muscle growth. A key clinical correlation of these two effects is to remember that patients who are taking insulin for therapy of diabetes often experience weight gain, and that's because insulin promotes the two effects I've shown on this slide, and that makes patients gain weight. Hormone-sensitive lipase is an enzyme that removes fatty acids from triglycerides stored in adipocytes. At the bottom left side of the screen is the chemical structure of triacylglycerol, otherwise known as a triglyceride. You can see that it has 3 fatty acids attached to a glycerol molecule. Hormone-sensitive lipase will break this down into fatty acids and glycerol molecules, and the glycerol molecules can then go to the liver, and the fatty acids can be used for fuel. This enzyme is inhibited by insulin, therefore there is less breakdown of fatty acids when insulin levels are high. This enzyme is also activated by glucagon and epinephrine, and that's the mechanism by which you increase your fuel supply from fatty acids in the setting of high glucagon or epinephrine levels. Other effects of insulin: it's been shown to increase sodium retention by increasing the resorption of sodium in the nephron. It also lowers potassium. It enhances the activity of sodium-potassium ATPase pumps in skeletal muscle. This will bring more potassium into skeletal muscle cells and lower the serum potassium level. This is the reason that insulin together with glucose is used in the treatment of hyperkalemia. When patients have dangerous or life-threatening high potassium levels, you can administer insulin and the potassium level will fall. You also administer glucose at the same time so that you don't accidentally make the patient hypoglycemic and cause a seizure. And then finally, insulin inhibits glucagon release. Glucagon is a counter hormone to insulin, so naturally insulin inhibits its release. So that's a nice segue into the pancreatic hormone glucagon. Let's talk about glucagon now. This is also a protein hormone just like insulin. It has a single polypeptide chain instead of two chains linked together like insulin. Glucagon is synthesized by the alpha cells of the pancreas, and this hormone opposes the actions of insulin. Therefore, the main stimulus for glucagon's release is a low plasma glucose level. Glucagon has many biochemical effects. I also discussed these in detail in the biochemistry modules. One of its main effects is to increase the liver breakdown of glycogen. This will raise the blood glucose level. Importantly, it does not break down glycogen in muscle. The breakdown of glycogen in muscle is largely triggered by calcium and exercise. Glucagon also increases gluconeogenesis. This will stimulate production of glucose coming from the liver. I told you before that insulin increases amino acid uptake by cells, especially muscle cells, for growth. Glucagon also increases amino acid uptake, but largely in the liver. This provides more carbon skeletons for production of glucose via gluconeogenesis, and you will see a fall in the plasma amino acid levels when glucagon levels rise. In addition, glucagon has the opposite effect of insulin on hormone-sensitive lipase, as we talked about a few slides ago. The glucagon receptor is very different from the insulin receptor. It is a G protein receptor. When glucagon binds, the receptor activates adenyl cyclase. This increases the amount of cyclic AMP inside of cells, and the cyclic AMP is the second messenger system here that will activate protein kinase A, and that leads to the effects of glucagon on target cells. Insulin receptors are found in lots of places, but glucagon receptors are found mostly in the liver. That's because most of the processes they activate occur in the liver. For example, the breakdown of liver glycogen to raise plasma glucose and also gluconeogenesis. In other tissues, you sometimes find glucagon receptors, but there's a much lower density compared to the liver, and you don't find any glucagon receptors at all in skeletal muscle because they do not respond to this hormone. And there's a nice review article at the bottom of the screen here if you want to read more. It describes all the places in the body where glucagon and insulin receptors are found. There are two clinical uses of glucagon that you should be aware of. The first one is in the treatment of hypoglycemia. If a patient is conscious and has symptoms of hypoglycemia, you ask them to drink juice or eat a cookie. However, if you encounter an unconscious patient who is hypoglycemic, there are two possible treatments. The optimal treatment is to place an IV and inject dextrose, which will raise the blood sugar level. However, if IV access can't be established, you can give an intramuscular injection of glucagon. This is very helpful out in the field when IV access isn't available, and this will quickly raise the plasma glucose level by glucagon exerting its effects on the liver. Glucagon is also used in beta blocker overdose. Patients who take an overdose of beta blockers present with bradycardia and hypotension, and the drug of choice is glucagon. The reason for this is because it will activate adenyl cyclase. This is the same thing that beta receptors do. However, it works through the glucagon receptor, not the beta receptor. So it will increase cyclic AMP and increase the amount of calcium in myocytes. This will help resolve the bradycardia and hypotension. Essentially, you are activating myocytes via the same mechanism as beta stimulation. However, you are getting around the beta receptors, which are completely blocked by the overdose of the drug. I'll finish this module by talking about two rare hormone-secreting tumors of the pancreas. The first one is an insulinoma. This is a rare pancreatic islet cell tumor. It occurs in adults with a median age of about 50 years. And as you can imagine, the key feature is fasting hypoglycemia. These patients have elevated insulin levels even when they are fasting because of the tumor. These patients classically develop symptoms of confusion and odd behavior from hypoglycemia. These are sometimes called neuroglycopenic symptoms. In addition, they tend to have symptoms of sympathetic nervous system activation from low glucose, so they will present with complaints like palpitations and diaphoresis and tremor. The diagnosis is to measure the fasting insulin level and show that it's high. You also need to show that the C-peptide level is high and the proinsulin level is high to prove that the elevated insulin is coming from the pancreas. One thing that is also in the differential diagnosis of an insulinoma is exogenous insulin administration. Some patients will administer insulin to themselves for secondary gain, and they'll present with symptoms of high insulin, but they don't actually have a tumor in their pancreas. When an adult patient has fasting hypoglycemia, the differential diagnosis includes exogenous insulin administration, Oral hypoglycemic drugs like sulfonylurea, these drugs increase insulin secretion from the pancreas. And then finally, an insulinoma. So you need to exclude these two causes before you can make the diagnosis of an insulinoma. The way you do this is by measuring the level of insulin in the serum, the level of C-peptide, and also a screen for hypoglycemic agents like sulfonylureas. If the patient is administering exogenous insulin, then the insulin level will be high, but the C-peptide level will be normal. Remember that C-peptide is a byproduct produced when proinsulin is cleaved into insulin, so the C-peptide level should be high if the insulin is coming from the pancreas. If the insulin is from an exogenous source, then the C-peptide level will be normal. In an insulinoma, you will see a high plasma level of insulin and also a high C-peptide level. In addition, the hypoglycemic agent screen will be negative. And then finally, if patients are overdosing on their sulfonylureas, what you will see is a high insulin level, a high C-peptide level, but also the screen for presence of sulfonylurea and other hypoglycemic drugs will be positive. The second hormone-secreting tumor the pancreas will talk about is a glucagonoma. This is also a rare pancreatic tumor that results in excess glucagon secretion. And this presents essentially looking like diabetes. The patient will have glucose intolerance. They will have elevated fasting glucose levels because glucagon levels are always high. One thing to know about this is that it's rare to develop diabetic ketoacidosis, and that's because insulin function is intact in the pancreas. So usually the patients don't get quite as sick as patients with DKA, who are usually type 1 diabetics and have no insulin function remaining in their pancreas. Because of the chronically high glucagon levels, these patients often develop weight loss. The liver is performing gluconeogenesis, which burns calories. This is consuming proteins and amino acids and leading to weight loss. In addition to weight loss and diabetes, another classic feature of glucagonomas is a peculiar rash called necrolytic migratory erythema. The mechanism of this rash in glucagonoma is poorly understood. It is a red blistering rash that is itchy and painful. It tends to fluctuate in severity, and it classically occurs in the genitals, buttocks, and groin. So a key clinical scenario that is very high yield to know for board exams is a patient who presents with new onset diabetes and a red itchy rash. When you see that, you should think of glucagonoma. You can make the diagnosis of a glucagonoma by demonstrating increased levels of plasma glucagon, and there are a number of treatments for this condition, but one of them that you should know about is the use of analogs of the hormone somatostatin. One of these that is sold commercially is called octreotide. Somatostatin is an inhibitory hormone. It's produced by the intestine and the pancreas and many other parts of the body, and it inhibits the secretion of many different types of hormones, including glucagon. So if you give this drug to a patient who has a glucagonoma, you will inhibit glucagon secretion from the tumor, and this can improve symptoms. Lastly, let me mention the MEN syndromes. MEN stands for multiple endocrine neoplasia. These are rare inherited disorders that I'll talk about in another module. They result in numerous endocrine tumors, but you should know that MEN type 1 syndromes are associated with insulinomas and glucagonomas. MEN type 1 classically involves the 3 Ps. It involves tumors of the pituitary gland, the parathyroid gland, and the pancreas, and the tumors in the pancreas tend to be insulinomas and glucagonomas. This syndrome results from mutations of the MEN1 tumor suppressor gene. And that concludes our module on the endocrine pancreas.